adds up, and that determines your risk for fibrillation. And if you have it, these are the things that up on the screen we tend to focus upon. So what are the issues involved with it? Well, it's a condition that happens to people that are older in age more often. And then, of course, the American lifestyle of smoking, which leads to lung disease, your obese, sedentary lifestyle, fast food, what have you, alcohol, lots of those caffeinated products like coffee or monster drinks or energy drinks, illicit drugs, which some people have used in the past, methamphetamine, cocaine, and the like. Now, in regards to alcohol, we see this pretty commonly in around November and December with the holiday season and holiday cheer. And this tends to lead to something of epidemic of fibrillation in the emergency room around November and December. And we call this fibrillation from alcohol holiday heart, really because of its use more commonly during the holiday season. So other things that we focus upon include sleep apnea, which is a rising reason for having this, poor control of diabetes, clogged arteries, whether they've been treated or not, or the development of a weakened heart muscle that the patient never knew about. That can do it. Or other conditions such as having an infection or a thyroid that's out of kilter, or your blood count is very, very low. And finally, your normal electrical system can fail. And if it fails with no electrical activity, people don't do well. It's called death. Well, sometimes the heart will develop its own system to keep the heart going. And one of the most common rhythms for that to happen is with fibrillation. So that if you have that situation and you install a pacemaker and back up the normal electrical system, there's no reason for it to fail. And guess what? Fibrillation doesn't recur. Okay. Now, what are the consequences of atrial fibrillation? Well, there's really three main ones, and I didn't necessarily put them in order of any particular category, but the catastrophic consequence is stroke. And this is probably the most devastating consequence of fibrillation that someone can have, and they may not have been aware of it. I'm sad to report that we've seen fibrillation for the first time in people that have had a normal life and they come in with a stroke and it's affected their life, and you hook them up to an EKG machine and there you see it for the first time and the person never knew about it. So the first reason they came on was having had a stroke. Devastating, absolutely. The other consequence is that if the heart is running in fibrillation at a high rate, say 130, 140 beats per minute, it can lead to a weakening of the heart muscle. The analogy is your automobile idling at 3,000 RPM 24/7. All of us know that if the car is running fast, the motor all the time, it's going to prematurely break down. In the eyes of the heart, it's a weakening of the heart muscle. And aside from those two consequences, people don't feel well in many instances. So I've talked to you about why it comes on. I've talked to you about the consequences of it. Now, let's talk about what are the ways that can be brought to bear out of all this. The most important thing is if there is anything in your lifestyle or choices that you've made in the past, those choices, if you continue to make them, will make it far more difficult to correct your heart rhythm and bring it back to where it ought to be, as in where you were when you were much younger in life. So the key thing is the risk factors that I mentioned to you in passing a couple of slides ago is very important. So with that understanding, what treatment choices exist? Well, we do have heart rhythm medicines that are designed to make the heart more resistant to going into fibrillation. And those are easily available and are usually by prescription and so forth. Now, it turns out that fibrillation, as I said, leads to, in some people, stroke. And we can estimate the risk for stroke by people's various medical conditions. And it turns out that this scoring system predicts with reasonable accuracy your risk for stroke. And if you're found to have a higher risk, it's usually recommended that you take a blood thinning medication to prevent stroke. The commonly used medications to prevent stroke, again, regarded as blood thinners, include Coumadin, otherwise known as warfarin, Eliquis, Xarelto, Pradaxa. These are the commonly recognized blood thinners. By the way, blood thinner in this particular situation does not mean aspirin or Plavix as a blood thinner. It's not useful in this particular situation. Okay, so that's a key point. Now, the other treatments to try to get you back to being regular beyond medicine includes an electrical cardioversion or a very specific procedure known as an ablation. Okay. So what is ablation of atrial fibrillation? I'm sure you've heard that discussed in passing with perhaps on television or someone you've discussed with who has had the procedure. It's a growing treatment, and it really involves a procedure similar but not similar to an angiogram. And what we basically do is we take special wires about the size of my necklace, and the wires go into the heart via the vein that lives in the right and left leg area. And what those wires do is they go into the heart to measure electrical traffic. And then the process of trying to go after fibrillation begins by placing a very special wire or catheter that's called a radiofrequency ablation catheter. And you take it into the area of the heart where it's coming from. Most of the time it's the left atrium. And what you do is you put the catheter that can deliver radiofrequency energy and cause burns in the heart tissue where the fibrillation wants to go to or where it's coming from or both. And that's essentially the procedure of how you go after it. It can last about 4 to 6 hours to do. It's a very complicated and detailed procedure and takes a lot of time. Because people have to lie still for 4 to 6 hours, and because movement can be very, very dangerous, it's common for this to be done under general anesthesia. You usually stay overnight and you return home the following day. You'll feel quite a bit fatigued, and it usually takes about 3 or 4 days, maybe up to a week, to get back in the saddle and being back to your usual self. And that's generally what we've seen with the patients over the years. Now, the success rates can vary depending upon whether the fibrillation is something that comes and goes, or if it's something with you 24/7, as well as if whether the heart is a strong heart or a weak heart. So those are some of the variables that determine how successful the procedure will be, short and long term. I will tell you that the long-term part of success depends upon the risk factors that I just talked to you about in the past or earlier in this talk. I mean, the way I like to think of it is fibrillation, is a rhythm that can be controlled, but it comes down to a two-way street of having the help of the patient and the technology that we can bring to bear. Okay, the other key point is that here at San Antonio, there's been about a 30-year history of doing sophisticated electrical heart procedures. And I'm pleased to say that the latest technology has been recently made available here at San Antonio with state-of-the-art technology and highly skilled practitioners able to use this technology to great patient benefit. Now, the other treatment that sometimes doesn't really see much of the light of day, but can be very helpful, is let's say you have been determined to have fibrillation. You've seen a doctor such as myself or someone in the cardiovascular community, and you've been put on a heart rhythm medication, and your heart rhythm, once you see the doctor in the office, is still irregular. But now we want to get you into the regular rhythm sooner than later. It may take several weeks to a month or two to get the ablation that you're desirous of having. Is there something we can do to make you feel better sooner than later? Well, that's what an electrical cardioversion is designed to do. And what it is we take a couple of electrodes, we put one in the front of the chest, we put one in the back of the chest, and then because an electrical shock can be very painful if you're awake, it's pretty common for people to get medication to sedate them and quote, put them to sleep, period, end of quote. The issue becomes, in some instances, sometimes the doctor will become in wonderment as to whether the patient's got a clot lurking in the heart. Is there a way to know for the doctor to determine whether it's a safe thing to give an electrical shock or not? Because if you think about it, if there's a clot in the heart and you give a shock and that shock kicks the clot out of the heart, it could go north to the brain and lead to a stroke, which is devastating. So wouldn't it be nice to have a way to know that ahead of time, whether there's clot or not in the heart? Well, there is this particular ultrasound probe called a transesophageal echocardiographic probe. Tongue twister, so don't say it quickly. And you basically can take this ultrasound probe, you can put it down the throat into the stomach, and it actually gives you the clearest pictures of inside the heart to make sure there are no clots in the heart. And if that turns to be true and is confirmed, then an electrical shock can be delivered to return that person back to a normal heart rhythm while they're under the effect of medication to sedate them or put them to sleep. From the time of starting the procedure without the need for this ultrasound probe is about 15 to 20 minutes, maybe another 10 minutes to do the probe if it's need be. The determination of whether a tube ultrasound probe into the stomach is really a physician-driven process, and there are different variables that go into play. But the key thing is to make sure that person has been taking their blood-thinning medicine as directed. Okay, I think this is our other way of addressing this. And now I think it's, I wanted to keep this straightforward and brief so that we have time to entertain questions.
Well, thank you so much, Dr. Abdullah, for that very informative lecture. We'll start the Q&A portion. I just want to make sure I have Dr. Abdullah. You can hear me okay?
Yes, good evening.
Wonderful. Okay, everyone can hear him okay? We're good to go?
Can we? Yes.
Okay, perfect. All right, we have a few questions. The first question is, why isn't aspirin useful to prevent stroke for AFib?
It's mainly because the blood thinning properties do not prevent the development of a clot. And basically, clots in atrial fibrillation are different from clots in heart attacks. So those differences give rise to the benefit of aspirin for clots in preventing heart attacks versus clots in preventing stroke.
Very good. All right. The next question is atrial fibrillation the only arrhythmia that can be treated with ablation?
No. Historically, ablation has been around since the 1970s. It was initially an open heart procedure that gradually gave way to wires and catheters placed into the heart, and ultimately radiofrequency energy became the preferred way of doing this in the mid-1980s. So excuse me, ablation as a process or a treatment has been around almost 40 years.
Very good. Thank you. The next question is, what are the EKG signs that can tell us this is the case of atrial fibrillation, since P waves are very difficult to see on an EKG?
So this can be very, very difficult in some instances. Not all EKGs or all cardia tracings or your smartphone or your watch or what have you can give you an accurate reflection, and sometimes it can be very difficult to determine. So this gives rise to the need for medically approved or recognized means of documenting atrial fibrillation. Sometimes it's extremely clear on your smartphone, watch, or what have you, but in many instances it's very unclear. So we really rely on standard EKGs as well as rhythm tracings that are extraordinarily clear in some people, but not everybody. So it's really, to answer your question, it can be clear in the medical devices that people have access to, Apple Watch, what have you, or it requires something more sophisticated that we use day in and day out on the medical side or the hospital side of evaluation.
Thank you, Dr. Abdullah. The next question is, what is the likelihood that you will need a second ablation?
The second ablation can vary, and we didn't talk about success rates because that's sort of a very individualized situation. But at the upper end of success rates, assuming you've controlled your risk factors that I've mentioned to you, and you your fibrillation is something that comes and goes, and your heart is strong as an ox, it can be said that your success rates can be as high as 85% or greater of it being highly successful. And in that group, about 25% can sometimes need a touch-up procedure to prevent this from happening. And so that is really a key piece of information that needs to be conveyed. So it varies from person to person.
Very good, thank you. If you have a family history of atrial fibrillation, does that put you at a higher risk of it? And if so, at what age should you get tested to find out?
We know that there is some sort of a genetic factor in play. There isn't any agreed upon timeline for evaluation, and so we would basically say that if you have fibrillation and it's happening in the absence of recognized risk factors, then we basically would tell you that it's important that that may have a bigger play or role, and therefore be evaluated. So it's more likely to be an issue if there's no established risk factors and you're in your 60s or 70s or much younger.
Very good, thank you. Is catheter ablation ever contraindicated for patients with AFib?
Absolutely. There are people that have many medical conditions that increase the risk of successfully performing the procedure. For example, someone who's got extraordinarily damaged lungs from years of tobacco or some other condition can lead to. Oh, I'm sorry. The music seemed a little bit interesting, but anyhow, so bad lungs, for example, will do it. Or you've got a problem with forming clots routinely, or you just had a stroke. Those are sort of examples where this procedure is absolutely contraindicated. If the lungs get better, or if some other poor condition reverses itself, which is not too likely in many instances, then the possibility can change. But I will tell you that once you get into the contraindicated period, sometimes it's just many times it's not the right thing to do. The one thing that I can say that may alter this decision is something such as having an infection, for example. You've had this history of atrial fibrillation, but now you've had some sort of a blood infection and you're recovering from it. Well, that's not the right time to do it. 6 months to a year later, when you've fully recovered and you're back to your usual self, then it becomes a viable option. And remember, ablation is an elective procedure. And so when you do an elective procedure, you want to make sure you're doing it in instances where there are no other conditions that could increase the risk for the procedure.
Why does a strong cough sometimes cause a fibrillation to cease?
It has to do with a large nerve system component called the vagus nerve, and it's designed to slow down the heart rate. And in some instances, that maneuver can break the arrhythmia. It's more commonly associated with regular rapid abnormal heart rhythms, which you give the term supraventricular tachycardia. And that's a fast, regular heart rhythm. Fibrillation is a fast, irregular heart rhythm. So while it can happen, coughing to straighten out the heart rhythm by the vagal response, we call it, it's more likely to be successful in the rapid, regular rhythms as opposed to rapid, irregular, which is atrial fibrillation.
Thank you. Is the procedure typically formed, let me try that one more time. Is the procedure typically performed under general anesthesia or conscious sedation?
The majority of the cases are general anesthesia for the reasons I've mentioned, the need to remain still, but there are instances where what you refer to as conscious sedation can be offered. It used to be a mix of both, but I believe, and because the cases can be very long, it's actually safer to be done under general anesthesia, because in conscious sedation, people can wake up at inopportune times and render the procedure risky.
How can the thyroid affect or cause atrial fibrillation?
Great question. The rapid rhythm of atrial fibrillation is favored by a high thyroid, which basically revs up the entire body. And a revved up body is going to increase the heart's likelihood to misbehave. And you can think of high thyroid as high adrenaline, and a high adrenaline is what drives up the risk for an increased heart rate of the normal electrical system and fibrillation of the atria by inference.
Thank you. Can taking Q10 help strengthen the heart for someone with AFib and heart failure?
Not aware of any data in support of coenzyme Q10 in the prevention, elimination, or reduction of risk of atrial fibrillation. I believe it has more of a role in heart disease outside of the electrical system of the heart.
Okay. The next question is, I had an ablation in 2008, and the physician said there was one lead that he wouldn't touch because it was too close to the aorta and might cause a heart attack. Does that mean I can expect more occasional fibrillations?
I think the best way to answer that question is that it's hard to sort of know what was implied, but at the end of the day, there are areas in the left upper chamber that you have to treat less aggressively because some areas of the heart are next to the food pipe, which we call the esophagus. And there are some other areas that one has to be very careful as well. So it's very possible that the doctor that successfully performed the procedure was being very uber careful in making sure that you had a successful procedure. And part of that may have been to be less aggressive in treating areas of the heart that are more sensitive to damage. And so I would say that kudos to that physician. I don't know that that translates to a higher likelihood of you going back into fibrillation. I do believe that it's, as I mentioned it throughout the pre-recorded session, it has a lot to do with the choices you make and the risk factors that you have and how good of a job you've addressed them after this procedure. And that it affects dramatically the durability.
Okay. And the last question is, will you require medication after the procedure to prevent a stroke or to prevent arrhythmias?
So, blood thinning medication after a procedure. The duration of the blood thinning medication is usually based upon your risk factors for fibrillation leading to stroke. That is to say that if you have risk factors in that scoring system that I mentioned earlier in the talk, well, that scoring system is not going to change regardless of what you do to make fibrillation go away, whether it's the electrical cardioversion, whether it's the ablation. So if you still have those risk factors and a scoring system that's above a certain threshold, you will need to be on blood thinning medication in perpetuity, regardless of any procedures that are done. So that's one issue. So that depends on what your risk factor or stroke is before the ablation. Okay, the other issue you asked about is heart rhythm medications. What I didn't tell you about the ablation is it's very common for people after the procedure to be put on a heart rhythm medication. Now, why would anyone be put on a heart rhythm medicine when you just successfully completed the fancy schmancy procedure? And that's usually a terrific question. And the answer is the areas that you treat with this particular procedure, the areas that are burned, can get so irritated that they themselves can be the cause of fibrillation soon after the procedure. So that people don't go home and have an episode of fibrillation, it's common practice to get a heart rhythm medicine after the procedure to make the heart more resistant to having fibrillation until the healing process of those treated areas completes itself. And that's usually about 3 months. So usually about 3 months, you get evaluated for the removal of the heart rhythm medication. And then the decision to remove the blood thinning medicine is based upon your risk for stroke at the outset.
We have one more question that came in, if you don't mind. Is an ablation done for supraventricular tachycardia?
Absolutely. In fact, that was the original indication for the procedure for the past 40 years. Atrial fibrillation ablation has really been around perhaps 18 to 20 years. So before the ablation of atrial fibrillation began in earnest, ablation was principally reserved for SVT or supraventricular tachycardia.
Very good. Well, Dr. Abdullah, I'd like to thank you again so very much for joining us this evening and for this wonderful lecture. It was very informative, and I know everyone appreciates the information. I'd also like to thank everybody for joining us this evening and also for joining us for any of the community lecture series. Just as a reminder, those will be available on our website, and we'll keep those up for a little bit of time. So if you didn't get an opportunity to see one or you'd like to watch one again, please feel free to take a look at those. And thank you so very much. Have a wonderful night.
Good evening to all. Bye-bye.
Bye. Done?